Thank you everyone for coming again, and thank you for last week's input and feedback. It was very useful. And today the last three groups are going to be here, and those of you who don't have 3 sheets of paper, one for each group, they're in the back.
For an individual with ALS named Sid, and I'm Kara.
I'm Hillary.
I'm Katie.
And I'm Lauren. And our group name for your sheets are the 3 Blondes plus Kara.
Okay, so just to start with a little bit of background about our case, Sid. He is a 48-year-old male with ALS, and that photo is a representation of what Sid might look like. He has spinal onset ALS and has limited communication ability due to an increased amount of fatigue that he experiences throughout the day. He does have a wife named Haley who did most of the reporting for our case study, and she reported that on a daily basis she has difficulty understanding Sid's basic needs and wants, and that's kind of a struggle for them. He does have consistent and independent movement with his right hand, which is really important for us to remember as we consider particular types of AAC devices that we might suggest for him. However, he does experience significant paresis or even paralysis everywhere else in his body. It did mention in the case study that Haley acts as Sid's remote, which typically just translates to that she controls a lot of Sid's environmental stimuli on a regular basis. So that's something else that we want to keep in mind to maybe make it a little bit easier for them. And he is mostly confined to his bed.
Okay, so in order to provide the most effective treatment to meet Sid's current and future communication needs, we realized we needed to know a little bit more about ALS. So, show of hands, who here feels like they can adequately describe it? Sorry, faculty, you cannot agree. All right, that's okay. Who here has at least heard of it? Okay, good. And who participated in the Ice Bucket Challenge? Awesome. All right, so just to make sure we're all on the same page, just going to give a brief lesson on ALS. So it stands for amyotrophic lateral sclerosis. It is a motor neuron disease, meaning that the nerves which supply our voluntary motor movements are the ones impacted. Generally speaking, the sensory nerves and cognition are left intact. So what's involved in a voluntary motor movement? For instance, how does Steve Urkel produce this expression on his face? Well, if you'll direct your attention to the board, I will illustrate for you a representation of Mr. Urkel's brainstem, which is also referred to as the bulb, and his spinal cord. And you'll see why all 3 of these things are important for a motor movement. But back to Steve. So Steve has to think a rhetorical thought, like, I got to pose for this picture. So that thought turns into a plan in his brain. And this plan is picked up in the motor portion of his brain. And from there, all of these motor neurons process that plan. And they transfer the plan to more motor neurons in Steve's brainstem, or his bulb. And then that plan is activated and the muscles of his face are innervated. Now, what about the other limbs of his body? He moved his arms and his legs. So the same stuff happens in the brain, but instead of the motor neurons sending it to his brainstem, they send it to motor neurons in his spinal cord. And then out from there to the muscles of his arms, his legs, etc. So now, okay, just gave a great, hang on, got a lot to say here. So out from his spinal cord to those muscles. Okay, yes, got it, we're back on track. All right, so people with ALS, these neurons begin to degenerate. And because these neurons are dying, they're no longer feeding the muscles with any information. So these muscles start to weaken and they eventually atrophy. We don't know why this happens, which is why there's no cure. But these neurons don't all degenerate at once. And that's why we have 3 different stages up here. In the early stage, the symptoms are limited to a particular region in the body, and this helps us distinguish the onset of ALS. So this might make a little more sense with this other example. So, for instance, if someone is complaining of weakness in their legs or their arms, basically their limbs, we can attribute this to the motor neurons degenerating in their spinal cord. And this would be known as spinal onset, which is what Sid had. Now, on the other hand, if someone is complaining of weakness with their speech and their swallowing, basically the facial muscles, we can attribute that to the motor neurons in their brainstem or their bulb. And this is known as bulbar onset. That pretty much constitutes the early onset of ALS. Now, moving on to the middle stage of ALS, the symptoms are much more widespread. Symptoms are much more widespread, but the main factor of this stage is that an individual's speech rate will decrease from an average of 150 words per minute to 120 words per minute. And their intelligibility will also decrease. So that's the main factor for the middle stage. Now, moving on to the late stage of ALS, individuals here will lose the ability to breathe independently because their respiratory muscles are giving out. So now that we have some information on all the stages, one fascinating thing to note about ALS is that many individuals somehow retain the ability to move their eyes, and that's clinically very relevant to us. So hopefully now that we've all had this brief lesson on ALS, you'll agree with my teammates and I. We have classified Sid in the middle stage because his symptoms are more widespread, his speech is no longer functional, his rate decreased, but he can still breathe independently. So now that we have his current status taken care of, we can focus on the family goal, which is providing Sid with the greatest level of independence. And I think everybody in this room can agree that if we were to provide Sid with some form of communication, that we could achieve this goal. So with that said, since Sid no longer has functional speech, we would like to consider the use of augmentative and alternative communication. The next question is, what kind?
All right, so now I'm going to give a brief overview of different terminology that we use with AAC. So AAC can be categorized as unaided versus aided communication. So unaided is only involving the person's body. So this might be eye blinks, gestures such as a thumbs up, and even facial expressions, versus aided, which requires some sort of external equipment or something to carry. And under aided, we can break that down into low tech and high tech. And as you can see, those are color-coded, but they're both under aided communication. So low tech is something that's non-electrical. Some of these examples could be PECS, which some of you are probably familiar with. This stands for the Picture Exchange Communication System. And this is just a protocol that uses the exchange of pictures for the patient to get a desired outcome or object. Another example is an alphabet board, which you can see on our slide here. And this just has all the letters of the alphabet, and you can do row column scanning to either get the desired first letter of each word to spell like if you were to go to BR, that would be meaning bathroom, something of that sort, or you can have spell out the actual name or object of that the desired object. And lastly, we have picture board, and this is usually in a chart format, just with photos and symbols that stands for what a person is ultimately wanting to achieve. And then secondly, we have high tech, and this is electrical. So this can be apps on an iPad or even a computer. We also have speech generating device. So that is, you plug in your message and the voice produces what the intended message is. We also have eye tracking on a tablet or laptop. So this is just using eye gaze to get that desired outcome. And lastly, a switch, which kind of works as like a cause and effect system. So just some pros and cons of each of them when deciding for a particular client. Some of the pros for low tech is that anyone can make these and they can't really break. So, but the cons of these are the communication partner has to know what questions to ask and how that protocol is being established. And then pros and cons of high tech is that the pros are that there's more options and more complexity for different messages, but the cons are that it's usually pretty costly and the funding that's associated with that. So now that we have a background on ALS and AAC, my teammates and I came to our clinical question, which is, for individuals with ALS, is a low-tech versus a high-tech AAC device more beneficial for AAC communication outcomes? So breaking that down into the PICO format, our P, which stands for population, is individuals with ALS. Our I, which is our intervention, which is AAC. Our C is our comparison, and we're going to look at high versus low tech. And O is our outcome, which is ultimately communication.
Okay, so now that Lauren has defined our PICO question, I'm going to be discussing the evidence that we use to actually answer that question and to apply it to our case with SID. We began this quest for our research this summer by searching a number of different databases, including Medline, PubMed, EBSCO, Google Scholar, and the Cochrane Review, using a number of different keywords, including ALS, AAC, high and low tech communication outcomes, and caregiver report. So from there, we were able to compile about 16 articles between the four of us, and then we gleaned the top 5 that we felt were the most relevant and salient to our case with SID. They are graphically depicted up here on the board. We did have one randomized control trial by Averill and their colleagues, a report of cases receiving treatment by Doyle and Phillips, and then some expert opinion cases by Fager and their colleagues, McKelvey and their colleagues, and Wall and their colleagues. So what did we find in these articles? We were able to find a couple of different themes that were threaded throughout, but up here we're kind of breaking them down color-coded based on the level of evidence that they felt. The first one being is that emotional disclosure improves quality of life for individuals with ALS. As they lose their ability to speak, they're going to need a way to communicate, and giving an AAC device of some sort is giving them the ability to communicate. This study showed that just being able to disclose how they were feeling about the progression of their disease really did improve their quality of life. The second thing I'm going to talk about is related to the stages of ALS and how that relates to the type of technology in AAC that we're using. First off, in the early stages of ALS, it was generally reported that they are using more low-tech or no-tech AAC devices, as well as their speech, that they have any left still, which usually in the early stages they most likely will. Examples of this could include handwritten notes or even just a simple communication board. And then they're also planning for what is going to be the next step as the disease progresses. In the middle stage, as verbal communication is generally lost, usually we're going to be seeing more of a high-tech or speech-generating device so that they can continue to give these complex messages that they may want to be giving without using their verbal communication. And then in the later stages, it was generally reported that individuals are using, again, no-tech and low-tech to communicate basic needs and wants. This would include the simple communication board, as well as the example was given, eye blinks to establish a yes and no response, or even to report on a pain level on a scale of 1 to 10. So 1 blink meaning 1, 10 blinks meaning a scale of 10, or a pain level of 10. Also, motor impairments that are a result of ALS are going to require some alternate access. So this would include scanning and eye tracking when using their speech-generating device, or even a low-tech alphabet board or communication board. And this kind of goes without saying, and it kind of goes along with the different stages, but the AAC system is going to need to evolve as the disease progresses. It's not going to be a one-size-fits-all for one person, and it's, of course, going to change as their disease progresses, as their communication abilities change and decline, as well as their motoric abilities. Another important point to make is that it was reported that individuals with ALS really liked being able to have a communication device that they were able to customize to themselves. The example was given of putting jokes that they like to tell on their AAC device because it allowed for them to still communicate how they had before they lost their speech and still kind of be able to feel that they were a member of their family and community. And then this is a little fun fact regarding the acceptance of AAC within individuals with ALS. It's reported that 96% of a sample size of 50 people accepted their device right away, and the 90% that either 90% accepted right away or there was some delay. Generally, the delay was based on either their family members being resistant to it or a physician telling them they didn't need it. But generally, it's accepted pretty readily because they realize their communication is declining. So now that we kind of have a background on the research, Kara is going to talk about how we apply that to our clinical case with SID.
Okay.
Sorry, my voice was gone there for a second. So, considering our clinical decision for SID, I guess the takeaway message from all of the evidence that Hillary just spoke of is that the type of AAC system that we're going to suggest for a patient really depends on what stage they're in when we begin seeing them. So that's kind of the takeaway message, and Lauren will talk about kind of some of our things that we wish we would have done to maybe change our question to answer that a little more directly for the future. But the most important thing to remember in regards to SID is that, like Katie mentioned before, we have determined that he is in the middle stage of ALS. So right now, if he is on the typical progression of ALS, according to the evidence that we looked at, that would place him in the need for a high-tech device right now. However, he is eventually going to progress to that later stage of ALS, so it's important for us to continue to monitor his progression and also train him on how to use some of these low-tech devices, so when that time does come, there is absolutely no gap in SID's ability to communicate, and he can just pick up and start using that low-tech device when needed. So, considering some of the high-tech options for SID, by recommendation of Dr. McCarthy as well. It was mentioned in his case, and I mentioned it before, that SID currently has use of his right hand consistently when he's not fatigued. So using something like a trackball or a trackpad, which a lot of people use with a laptop, would be something possible for him to select until that time does come when he can't do it anymore. So here's kind of an example of what I'm talking about. So he could just use this and select whatever he wants to communicate on the laptop, and he could download any various apps or anything with a voice output that he can program to select and communicate what he needs to communicate. Additionally, just like the progression of ALS states, there is going to be that decrease in ability into the later stages, so also planning for the future of when that movement of his right hand does go, introducing something with eye tracking. As Katie stated, that is something that stays pretty intact throughout the progression of ALS. So something like the PCI Go, which also connects through a laptop, and as you all can see, this is kind of what it looks like. Well, it's not kind of, it is what it looks like. And it connects through a USB into any laptop, which would be great for SID if he is going to use this trackball strategy, because he can use the same laptop and the same apps that he had been using, just selecting it in a different method. So that'll be easy for him to transition to when that's necessary. And since he is connecting through a laptop, he's not limited to just a speech-generating device or those possibilities. He can also use it with the internet and other things and stay interactive with family and friends on social media and have those additional options. So just to give everyone a little bit of familiarity with the PCI Go, we do have a short video clip.
Presenting the Toby PCI Go, next generation eye tracker that gives you hands-free computer and tablet access through gaze interaction. The Toby PCI Go is ideal for users who need an alternative computer access method. For example, those with Lou Gehrig's disease, ALS, or a spinal cord injury. The PCI Go works perfectly on laptop and desktop screens. With the iMobile bracket, you can also use the PCI Go on standard Windows Pro 8 tablets. Running on Windows, the PCI Go allows you to work with virtually any application, but instead of using a standard keyboard and mouse, you use your eyes to select, click, drag, drop, and type. The PCI Go easily attaches and detaches from your desktop or laptop using a magnetic mounting bracket and a USB connection. Add the iMobile bracket and you can use the PCI Go with your Windows tablet. This makes it easy to bring the PCI with you at all times, in school, at work, at home. After a quick installation and a calibration, you are ready to play games, do spreadsheets, surf the web, Skype, and more. The PCI comes with the revolutionary Toby Gaze selection. Gaze selection makes it possible to control your desktop or any other application through an intuitive two-step process. This two-step process makes it so much easier to control your computer. It significantly reduces the risk of unwanted clicks, giving you more relaxed, almost pixel-precise computer access. To write texts, messages, or URLs, you can use the on-screen keyboard that is built into Gaze selection, or any of the keyboards that come with the optional Toby communicator. A tremendous leap forward in assistive technology, the PCI champions people with all abilities, with improved communication, enhanced emotional well-being, and ultimately greater.
Okay, so and then it was going to try to sell it to you guys and tell you the website, and we didn't get over that. So one additional note that I did want to make before we move on to the environmental switch is that typically for an individual with ALS, it's recommended and hopeful that as SLPs, we are able to begin our intervention with them as early in the progression as possible. That is because if they still have their speech ability in the early stage of ALS, there's a process called voice banking that can be incorporated with an AAC device like this one, and that allows them to record common phrases, words, and things like that in their own voice that can then be translated onto an AAC device once their speech does go. And as Hillary mentioned, that would maintain their personality, that would allow them to actually feel like they are speaking rather than speaking through a communication modality that does not sound like them. So ideally, that would have been great to do with Sid, but because he came to us in his case in the middle stage, that was no longer possible because his speech had deteriorated already. One last high-tech option would be an environmental switch. As I mentioned in the case study at the beginning, Haley, his wife, acts as Sid's remote, and it controls a lot of the environmental stimuli in his environment. So connecting a switch, which hopefully everybody will be able to see this. Oh, it turned it on. Like this, and then connecting it through a box like this, which I'm sorry, I'm restricted by cord length. You can just have Sid hit this button as long as his right hand is still functional, and he can turn on anything that has an on-off button that can maintain being on. So here the fan is just turned to high or low. He can hit that button and automatically his fan would come on. That would increase Sid's ability to control his environment, which would probably increase his self-esteem. It would cut down on Haley's need to constantly be checking on him and seeing if he needed adjustments in his environment. And it would also probably allow for Sid and Haley to communicate about things other than his basic wants and needs and have some more meaningful conversations because those needs would be met quicker. And then finally, considering when Sid does inevitably get to that later stage, some low-tech or no-tech options that we had considered is a partner-assisted communication board or an alphabet board. And here's an example of what those would possibly look like. So it has all of the letters, and Sid would be able to scan, and then Haley would help him select which one he wanted, and Sid would blink or use a laser, for example, to select the letters that he wanted. And as Lauren mentioned before, could do like BR for bathroom, which is the process of encoding, to shorten a word to make it easier for some of those time-sensitive things that you might need to request.
All right, so reflecting on our process, we broke this down into 5 different steps. One being we formed our clinical question. So if we would have done this a little bit different, we would have included our client-specific stage of ALS into that question. Second, we found our research, so we found it important to find a wide range of articles and then narrow those down. Thirdly, we analyzed our research, and we did this by using the EVP pyramid that you saw in our presentation, and also the rating sheet that Dr. Malwista provided for us. Fourth, we integrated external evidence from experiences. So we acknowledged the fact that we lacked some experience with ALS and some of us even with AAC. So we consulted with Dr. McCarthy, who was a great help to us. Fifth, we evaluated ourselves as evidence-based practitioners. So like I said, we lacked that experience, but we did see this as a learning curve, just in the fact with this profession that we're always going to be gaining new evidence and we're always going to be having to go through this EVP process with different questions we have.
And finally, future directions. What's next? We came up with a couple of ideas, the first one being continued high-level research. As you saw, much of our research that was specific to ALS and AAC was more case histories or case reports and expert opinions. So it would be good to see more controlled trials or experimental designs to see how different specific AAC devices work with individuals with ALS. Of course, that's hard depending on, with ethical concerns, you can't withhold a treatment from one group, but again, it's just something to keep in mind. Continued research on ALS, specifically in the domain of communication for us. Just continued understanding of where the communication breakdowns are going to happen depending on the stage, as well as language breakdowns that could be happening as the disease is progressing in the later stages. And then finally, more on AAC in general, thanks to our very own Jamie and Dr. McCarthy. That's a reality right here at Ohio University for making that dream come true. Of course, technology is always evolving. As such, AAC technology is going to be evolving, and we need research to back up what we're doing. And then lastly, more ALS-specific apps or devices, similar to what we see with autism spectrum disorder. There's apps such as Autismate that are specific to that disorder. Ideas we had for this could include making sure that individuals can have a specific vocabulary, maybe that's relevant to their disease, as well as being able to access the devices as easily as possible and create the most complex message that they would like to do. Of course, as fatigue and motor impairments are a big factor with ALS, the type of access is going to be really important. And finally, we wanted to leave you guys with this quote. This was in one of our case studies of a wife of a woman whose husband had passed away from ALS. And this was her kind of reflecting on his care after he had passed away. She said, out of all of the equipment in here, meaning the ventilator, that stuff is life-sustaining, meaning the AAC device. Greg still felt like his life was the ability to communicate. That's what made him the person he is, his ability to communicate his personality. And I think that is a nice, kind of ties everything in a bow and shows how important our role is in these individuals with complex communication needs. I mean, you think about, you have medical doctors that are supplying, ventilators, things like that, but our role is really to keep their quality of life and making their last years on life with their loved ones the best that they can be. And there's our references, in case you're wondering.
And we wanted to thank Dr. McCarthy for all of his advice. And as our group name states, 3 blondes plus Kara equals success. So thank you very much. Are there any questions?
We're probably going to be doing this next year.
Maybe.
We will be doing this next year. Do you have any tips or suggestions that may help one of the first years out?
Start early.
That's exactly what I was
Yeah, I
going to
think we had our PowerPoint kind of laid out the first couple weeks of classes this semester, and it just helped take the stress off because you're doing the praxis stuff and getting your life together. So just having it so that you can make little adjustments throughout the semester without being freaking out about
the big picture, I guess.
I would piggyback off of that and also say, while planning ahead, also have consistent meetings, because it was inevitable we would get distracted and start laughing. And so like having those meetings every so often really helped to kind of peel away at it slowly rather than feeling like, oh my gosh, we have to do this and we have to meet for 3 hours. And so that would be my thought on that. Yeah. Anything else you can say?
In your research, excuse me, in your research of the literature, when you're reading these articles, did you find any of the descriptions or conclusions that are counterintuitive or opposite to what you would expect based on your clinical experience? So, for example, the high versus low tech being applied to people with people in different stages.
Yeah, I mean, of course, there's going to be variations to everybody. I know there was a case study, and I mean, there were individuals in the later stages that were able to still access their high-tech device. So it's really just going to depend on the person and their progression, individual progression.
However, most of the articles that we found, which was why we were kind of able to generalize it with the way that we did have it typically broken up into those 3 stages and kind of that general progression of low to or no, high, and then low. But also another thing to think about too would be with the progression of technology and eye tracking, since we know that that is something that sustains throughout, and having high tech being incorporated with eye tracking, you might start to see a change, or it maybe has already, to having high tech even in the later stages, because you know that that's a set capability that they're probably going to have even into their last days. So.
Yeah, and generally the people that were using, if they were using their higher tech device, it was through alternate access.
Does that answer your question?
Yes, thank you. Can I follow up with another one? This one will be easier. So Hillary mentioned that 96% of the 50 individuals in that one particular study were accepting the use of AAC devices.
Yeah.
So that means 4% or 2 people did not really want to use the device at all. Do we have any information about
Yeah,
why?
it actually said that those individuals also had comorbid dementia, like prefrontal lobe dementia, and that's why that they weren't choosing to use AAC devices. I guess they just weren't cognitively able to make that decision. So that was the reasoning for that.
Okay, thank you.
Right, so we are going to go ahead and get started then. So we are team, and I am Leslie.
I'm Nick.
I'm Rachel. I'm Courtney.
And our evidence-based practice project is looking at individual versus group therapy. So our case study is about Tessa, and this picture resembles Tessa. She is a 4.5-year-old female who currently lives with her mother, grandmother, aunt, and uncle, and her father is in correctional facilities. Due to frequent moves, Tessa has never been enrolled in a Head Start program or preschool. Social Services is very familiar with Tessa's family and in 5 weeks is reassessing the family dynamic to determine custody. Tessa was seen by a general physician and a medical student for a checkup, and then they referred her to a speech and hearing clinic because she was difficult to understand, had difficulty following simple directions, and spoke very little as she was extremely shy. So based off of the reports that we were given, we believe that Tessa's expressive and receptive language severity is moderate. So, our PICO question. Our PICO question is, for a child with an expressive and receptive language delay, would individual therapy be more effective than group therapy at improving functional, expressive, and receptive communication abilities? To break it down, our population is children with an expressive and receptive language delay, and the intervention that we are looking at is individual therapy, and we are comparing that to group therapy to see which one would have the better outcome at improving functional, expressive, and receptive communication abilities.
Okay, so based on the case study, we determined that Tessa has expressive and receptive language delay. And right here we have the Linguist Assistance Guide for Communication Milestones. We have a few items on here to show you guys where Tessa should be at her age. She's 4.5 years old currently. So expressively, she's about 70% intelligible, and at minimum, she should be 75% to 90% intelligible. And this can account for her for age-appropriate errors as well. She should use direct requests with justification, which is like, I'm tired, I want to go to bed, I'm hungry, I want to eat. They should make sense and have meaning to them, not just I'm tired, you know. She should also use words to invite others to play and have 1,600 words. And both of those kind of go together because she has very limited social interaction with peers. And she had very few words during her initial evaluation. But it could be due to shyness as well, just because some kids are shy when you first see them in the clinic. Receptively, she has difficulty following one-step directions. And by her age, she should be following three-step directions, which could be go upstairs, brush your teeth, put your shoes on. And she can't even do that right now. She should also be able to answer simple questions about herself. What's your name? How old are you? And understand the sequence of events and stories as they're being read to her. And now we're trying to find the right intervention for Tessa, either individual or group therapy. And those will be based on the different language severities. And I'll go through some of the benefits of each one real quick. So individual, you get that more intensive one-on-one intervention. It's helpful, there's less distractions, and it's probably for more severe cases, but it can be used with all cases as well. For group therapy, you can blend therapy goals all together. So if you see that picture right there, you have a bunch of different students, and you're using one therapy technique with all of them at one time. So you're blending all the goals together. And with that, you get the social interaction and peer modeling to help them reach their goals. And the goals you learn from group therapy transfer over better to real-life situations than in individual therapy. And before we do the polling, I want to tell you guys the difference between group therapy and therapy in a group. So group therapy is everything I just explained right there. It's what's in the picture. You get the social interaction, the peer modeling. And the therapy in a group is having, you still have a group of kids, but you're working on individual goals one at a time, just like that. Okay, and now we're ready for the polling. So the first question I want to ask you guys, we want to know who here has done individual therapy for expressive and receptive language? No, individual therapy. Individual.
With this question right
Yeah.
here.
So who has done individual therapy for expressive and receptive language here? Yeah, A is yes, B is no, sorry. Oh yeah, press submit, everybody.
Oops.
So is everybody got it?
Well,
Almost there. So as you can see, like primarily, there are more people who have done individual versus expressive and receptive therapy.
Okay, next question. You guys ready?
right.
We want to know, everybody said yes to the last question, who has done group therapy for receptive and expressive language? And remember, group therapy is the social interaction and the peer modeling, not therapy in a group.
Remember to click submit.
All right, good. Okay, and last question we have for you guys is, how many of you guys have done only receptive therapy, only group therapy with receptive language skills?
Wait, what?
It's group therapy with receptive language. Yes, yes.
So if you answered yes for the last question that you have conducted group therapy for expressive and receptive, go one step further. Have you done group therapy for just receptive
Only
language
receptive.
goals?
Yeah. So we just wanted to see if your guys' responses correlated with our research, and it seems like it has so far. So, and Leslie will explain all about it towards the end. Yeah. Okay.
So you can see that there's significant differences as the levels go down further. And we'll begin to talk about that in a minute. So thank you all for participating in our opinion of our research here. Now let's talk about how we began our research journey. So first we started identifying our terms for our research, and that's obviously being with expressive and receptive language, along with individual and group therapy. We then set our parameters in identifying our age range for our population and the publication date of our articles. We wanted to select the highest level of evidence, so that would include our meta-analysis and any systematic reviews. And overall, we had a large array of databases so that we could incorporate different articles that really related to our specific PICO question. And this is something that we really needed to branch out in finding different databases so that we could have that support for our question. So out of over 16 articles that we read, we narrowed it down to the most relevant 6, and we're able to chart them here based on their levels of evidence. Based on the sheet that Dr. Malavista gave us, we identified articles having the highest evidence as a level 7. So that would also correspond with the red at the top. The lowest level of evidence is purple at the bottom, and as you can see, we primarily fit our cases into having a randomized control study and a control study without randomization. In order to encompass primarily our Boyle articles, we gained that there's inconclusive evidence, whether individual or group therapy comes out with a greater outcome. They said that there was no significant p-value comparing the two. However, in the end conclusion of the Boyle articles, they described that there are many other benefits noted, like the cost and the social and pragmatic interactions that the children have together. So our articles also identified that both individual and group therapy helped with expressive language impairments. So that's a good thing. Comparing dyad versus small group therapy, and this is really related to the Tigerman article. Dyad sessions are when you have 2 children per 1 clinician, and a small group session would be about 6 children per 1 clinician. So you can see here that in their conclusions, they ended up having more success in the dyad sessions because there are 2 children with 1 clinician. And this really allows for them to have a good communicative environment to allow for facilitation, to allow for the peer modeling, the group interaction, age-appropriate models, but it also allows for the SLP to come in and provide feedback, modeling, and prompting for those children. So in the group therapy session of about 6 children, it's a little bit more difficult for the therapist to be able to do that. So they found that it's more constructive for a small group session. And overall, through our articles, we gained benefits for group therapy, as I mentioned before, about cost. It's much more cost effective to have your time spent with multiple children rather than one-on-one sessions spread out. The children gained improved confidence through their interactions with each other and having that social link between other children. And they also modeled better behavior because they saw peer modeling and received good feedback from them. So now Courtney will begin to describe how these findings conclude with our clinical evidence.
Okay, so as Rachel just said, after considering all the evidence we found and narrowing it down to our top 6 articles, We consulted with a couple of clinical experts that we have here, as well as reflecting on our own clinical experience. And then most importantly, we wanted to make sure we kept Tessa's family and their values in mind. Her family really wants her to communicate more efficiently with them, as well as starting to get some social interaction with peers, because that's not something she's gotten to do yet in her life. So after we looked at all of that, we decided, kind of as Rachel said too, that group therapy would be the most beneficial option for Tessa at this time. More specifically, again, according to Tigerman, we wanted to do a dyad session of 2, maybe 3 kids with Tessa. This way she gets more individualized attention from the clinician, while also getting social interaction and peer modeling and engagement that way. So it kind of gave her a little bit of the best of both the options. And then again, since Tessa's language was considered moderate in severity, this is an appropriate severity level for group therapy. We also thought it would be really important to reevaluate Tessa in 5 weeks for a couple of reasons. First of all, since this would be her first time in a social environment with peers, we're curious to see how much of her language evolves naturally just from having that stimulation around her. And then depending on what we find from that evaluation, if it doesn't seem like she's getting enough support that way, we could do a mixture of individual and group therapy so she can still receive the social interaction in group therapy, but also if she has more severe goals that evolved at that point that we aren't aware of yet, we can kind of target those as well. And then finally, since social services are involved, as Leslie said, they're reevaluating for Tessa's custody in 5 weeks, so this is something we really needed to keep in mind in our initial clinical decision. Okay, so some limitations and suggestions, you'll see these kind of correlate with each other a lot. 2 of the big ones that we found were age, the first one being age of publication. We tried to look for articles in the last 10 years, but we had a really hard time finding ones that are recent and relevant to our question. We ended up having to expand to about 10 to 25 years ago, so they weren't very recent, and that's something that we would really like to see more of, stuff that's more recent and relevant to current clinical situation. Also, the age of the participants in the studies that we did find, they focused on birth to 3 and school-age children. They didn't really look at the 3 to 6 year age range, since Tessa's 4.5. We'd really like to see some stuff focused on that little middle age group. Also for group therapy, we were very surprised to find very little evidence about group therapy, and especially comparing group and individual therapy. So that's something also we'd like to see. And along with that, the ones we did find that looked at both therapy types very rarely, if at all, discussed the receptive language outcomes of those kids. And then one final future research thing that we were interested in is looking at the carryover effects of both therapy types. We believe that the group therapy would help with generalization to other contexts, but that was mentioned a little bit in articles, but we'd like to see more substantial evidence looking at the carryover.
Okay, so to explain a little bit about our process. We began our process this summer when we chose our case study. And then from our case study, we developed our PICO question. And from the polls that we did earlier, we saw that many of us in this room have not conducted group therapy, specifically group therapy targeting receptive language. And this is consistent with the amount of research that we have found. When we first started this process, we were excited and thought we were going to find all this research that would help us answer our question. However, that was not the case. And when we were researching our articles, we had a difficult time finding evidence that would support our question. So when we analyzed our articles, we could only find only a few of the articles out of the original 16 had relevant points or findings that we could use as evidence. So we really had to rely on our clinical knowledge and clinical experience to answer our question, along with integrating the evidence that we did find. Lastly, we collaborated with Dr. Bonino and Mrs. Kennard for their research and clinical expertise. And they agreed with us that at this time, group therapy would be the best decision for Tessa based off of our research findings, clinical knowledge, and keeping in mind Tessa and Tessa's family's values. So we would like to thank Dr. Bonino and Mrs. Kennard for collaborating with us throughout this process. We would also like to thank our classmates and faculty members who provided input on our presentation and the poll system that we used. And lastly, thank you to everyone here for participating in the poll. You are all awesome, and we really appreciate it. Are there any questions? Yes. Okay.
next.
In any of your research, did you ever come across anything that said which type of therapy had improvements in the shortest amount of time? Like, does individual therapy, do you see changes quicker in individual therapy than you do in group therapy? Did you come across anything like that?
Nothing ever mentioned the impact of like timeline scales. It just kind of looked at severity levels, based on where your client would be placed for individual and group. But it didn't actually ever assess that specific question.
Also, it had a lot of them weren't expressive and receptive language. There was a lot of SLI, a lot of autism, so it wouldn't be as relevant to our research here. So I don't want to give wrong information.
So we are the last group, and we are the grads, or if you don't remember your diacritics, we're the stressed grads. And I'm I'm Ashley.
I'm Kristen.
I'm Morgan.
And I'm Mohammed.
And our project looked at ASD, and it compared IDT and PECs. So as Mrs. May would say, we have a bunch of alphabet soup in our presentation. So you're probably wondering, what in the world do all those acronyms mean? So I'm going to tell you. So the first one is ASD, which is Autism Spectrum Disorder. And these are children or people who have deficits in social skills, behavioral skills, and communication skills. And like the name suggests, there's a variety of how these deficits can be shown. Not two kids are going to have the same type of deficits, or they're not going to look the same. You can have kids that are going to have mild deficits, maybe severe deficits, in any of these three areas. Deficits in social skills can be limited nonverbal skills, and they can have limited emotional responses. They may have a really hard time identifying or understanding your facial expressions if you look angry, upset, or anything like that. Behavioral skills, they like routines, and as many of us know, life doesn't go the way we want it to go, so routines, you want to try and teach them that how to not be, I'm using my words, how to not be set on routines, and that life just kind of goes the way it wants to go. And they also have repetitive behaviors. They may get stuck on maybe objects that spin. So communication skills, they can have varying degrees of impairment in limited topics. Sarah and I had a client together our first year, fall semester, and all he liked talking about was SpongeBob. And trying to get him away from the SpongeBob topics was a really hard task. So, and if we didn't talk about it or do anything related to SpongeBob, he would get really upset. So just like an example of limited topic. The next acronym is PECS, which is a Picture Exchange Communication System. And this is a form of augmentative and alternative communication where pictures are exchanged to facilitate communication. And in the bottom corner, that is an example of a picture board. And basically, in order, we have a video showing this, is in order to facilitate communication, you hand your communication partner a picture, and you get the desired object. So, here's a video.
Oh, it's fine.
Yeah. So in order for her to get the Rubik's Cube, she has to give her communication partner a picture of the Rubik's Cube, and then she gets the Rubik's Cube. All right. And the last acronym is IDT, which is Intensive Behavioral Treatment. And this is using positive reinforcement to elicit a positive behavior and reduce harmful behaviors. And we have a video for this one as well. This explains.
The first video in the series will provide you with an overview
of one of the basic tools used in intensive behavioral interventions, the discrete trial. The discrete trial is made up of several distinct components.
Nice sitting, good girl.
It begins with the SD, or discriminative stimulus.
Do this.
This is the instruction given by the therapist to the child. Next, the therapist either waits for the child to respond or provides some help in the form of a prompt if needed. Finally, once the child has responded, the child is given reinforcement, a reward for a correct response, or a correction for an incorrect response.
So one thing to know is that with IBT, it's a really intensive treatment protocol, and it's usually about 35 to 40 hours a week, and it's a one-on-one therapy. And you'll find out with our client the positives and the negatives with IBT.
And something to note with IBT is also that it's more of a theory and instead of like a protocol. So there's actually a different subsets of how you can use IBTs in theory, and Morgan's going to get into that.
Yeah, so let's see. How did we get to this point that we're at right now? So in the summer, our group chose a case study, something that we thought we might all enjoy sort of researching a bit more thoroughly. We developed our PICO question, which was based on the information that was provided in the case study. Then we began researching our treatment methods utilizing some of the databases provided by the Ohio University Library, using some of these search terms, ASD, PECS, IBT, to sort of hone in specifically on what our PICO question is, which we will define a bit later. And in the fall, this is when we started analyzing our research a bit more thoroughly. So we compiled everything together, and at this point we were trying to make our comparisons. We met with Dr. McCarthy and Mrs. Taylor to sort of define exactly what we were trying to do, maybe a bit more this cohesive project that we're trying to get done. Here we are, with this presentation, it's happening. So now we're implementing this evidence in the form of this project. So how about it? So now on to this is the critical element. This is this kid that represents Tommy. He's a 5-year-old male diagnosed with autism spectrum disorder. And what's been happening is he's been acting out in class. His social communication is significantly hindered. In the case study, the teacher had mentioned to the family that she hadn't really found an educational strategy that had really benefited him very well, and she's spending a lot of time with him in the classroom. And the family is ready to try a new intervention strategy to assist him in his communication. So some of the previous interventions that were used were social stories and American Sign Language. So the social stories were a bit advanced, I guess, for this Tommy's age. The parents were impressed with the idea, but they thought, okay, maybe we're not ready for this yet. And with ASL, they thought this form of communication might not benefit him when interacting with his peers, because if you don't maybe understand that language, then you're not really communicating effectively. So, like we mentioned previously, IBT is being considered as well as PECS for the intervention strategies. We're going to go over the pros and cons, and then clearly the information that we've gathered from our research. So he has limited communication skills. They're really wanting him to begin initiating interactions with his peers. Okay, I think we can move on. Great.
So as Morgan just mentioned, and I would like to re-emphasize, the person and Tommy in our case is at the center of all this EBP process. So with this person-centered approach in mind, we just constructed our clinical question, which includes 4 elements. So P stands for population, which in our case is children with ASD, and I I stands for intervention, which stands for PECS, and then C for comparison, as we compare PECS with IBT, and O stands for outcome, that we would like to see the improvement in terms of social skills. So just within these two together, our clinical question is, do the social skills of children with autism spectrum disorder improve more with the use of PECS or IBT? So because our role as clinicians is kind of to look for just a quest for truth. So we would like to eventually use the evidence which we can rely on. So as you go up the pyramid, the level of evidence is more trustable. So, but we could just find one article that directly compared the two approaches of PECS and IBT, and the others. So the ones in red are the ones with emphasis on PECS, and the ones in blue are the ones with emphasis on, the ones on black are the ones with emphasis on IBT. So that's it.
So after we went through all of that evidence, because we had more than 16 articles, we decided to find 3 best supporting evidence. And these are the 3 that we came up with. The Vismari and Rogers article was our one article that kind of looked at both PECS and IBT. And it was a systematic review, and it looked at the behavioral treatments for children with ASD. And this is kind of when we started to realize that PECS is kind of like is a skill-based behavioral model. And when we started to realize that PECS was kind of based on IBT itself. So which made our clinical question a little bit more difficult to work around. So the results for this is that we found that with PECS, it has improvements in eye contact, joint attention requests, and initiations. Along with this article, it also looked at IBT and all the therapy approaches with that, and they kind of had the same benefits or results as well. With the Lerna and Esposito article, which was written in 2012, it was a between groups comparison, and it looked at PECS. And they had 2 groups of children with ASD, and they were divided up by mileage away from the facility. So if they were between 30 and 50 miles away, they were in the control group. And if they were less than 30 miles, then they were in the intervention. And they found, getting ahead of myself. So they did PECS, and they also had a conventional language therapy, which they did 3 times a week for 30 minutes each for 6 months. And they found that children receiving PECS did significantly better than the control language group in social skills. So for the joint attention, initiation, and requests. And then the final article, which looked at IBT, which was also a systematic review written by Dawson, Dine, Berner, and Karen, really synthesized their current findings about IBT, and they also found that IBTs are effective in improving language, cognitive abilities, social skills, and adaptive behaviors. So what you're really seeing is both IBT and PECS are really, really good at improving both social skills and joint attention and everything like that, which is why our clinical decision was a really hard one to come up with.
So now just to break up and include information from all of our articles, not just the ones Ashley talked about. For PECS, we divided up into pros and cons. So pros, they had significantly higher skills on the BAB social domain, which is the Vineland Adaptive Behavioral Scale. And that was in the Lerna article. We also, many of our articles focus not specifically on social skills, but also on the communication skills, which is a really big one. And a lot of those articles showed the direct impact on the emergence of speech. So PECS has been shown to help speech come about, even though they're using pictures. Another thing is the social communicative behaviors improved with the problematic behaviors reduced. And this is really important in Tommy's case because the teacher was saying how he was being disruptive in class, and PECS can really give him a way to communicate, so that can help those problem behaviors reduce and help those social communicative behaviors the family really wants to focus on. Some of the cons, you have to have training for the communication partners. So whoever Tommy was talking to with the PECS would have to know how it would work. And since he is 5, he would probably be talking to 4, 5, and 6-year-olds. So you would have to teach them how he's using it and what it means when he gives them the picture. And then also a big thing with PECS is time. There are 6 steps to PECS. You start the first step, which is just what you guys saw in the video. You get the picture and you hand it and you get the item. And you have to work through mastering all the steps until you move on to the final 6 where you can comment on your own, you can form phrases, and you can give your wants, opinions, and needs. Most of the articles look between 6 months to a year or longer. And the one article, the Learn article, only focused on steps 1 through 4. They didn't even go into the higher steps of PECS. So really you're talking about a lot of time that it's going to be to implement PECS, but it will look specifically at focusing on those social skills that the family really wants. And looking at our IBT intervention, which is really the theory behind everything, so PECS kind of falls in there. The pros and cons of this one. So they found that IBT in general doubles the rate of social interaction, and then solitary behavior is cut in half. Again, you have your reduction of those problematic behaviors, so that's really important for Tommy again because they can help him stop acting out in class and disrupting and letting the teacher focus on other students as well. And there were a significant improvement of social skills. Again, they really didn't go too far into this because their main thing is communication. So you kind of had to delve into the papers to find if social skills were a benefit on the side, which it was. And then some of our cons, as Ashley mentioned, it must be intensive. It's usually between 35 to 40 hours a week. We found one where a case where it was about 20, but that's still a lot of therapy during the week. It's usually one-on-one, either with the aide or the SLP, usually really helping. And then the biggest con for IBT is it focuses on a variety of skills each week. So the first week they're going to start with him sitting in his chair, and once he sits in his chair they give him a reward, and they do that until he masters it, and then they move on to the next skill. So it's not really going to be focusing on just his social skills of interaction like the parents want. It's really going to focus on all those variety of skills, and the parents really didn't say that they needed that. So now that we've gone over the pros and cons of both, we have our opinion of what we would choose to do. We really are interested in what you guys think. So we're going to take a little poll. If you think that you would choose PECS for Tommy, please raise your hand. Just raise it. Just raise your hand if you choose PECS. Okay. Does anyone want to offer why they would choose PECS for Tommy? Okay, well, we'll get into that. Would anyone choose IBT? Do you want to tell us why, Dr. Lee? Okay. All right, so moving on. All right, so our clinical decision. We've asked our question, we accessed the research, we appraised it, and now we're getting to where we're going to apply it. So using the clinical expertise, which we used ours, limited knowledge, and we also talked to Dr. McCarthy and Mrs. Taylor, looking at the research that we found, and also the patient values and preferences, which is really what the parents want him to focus on is his social skills. We are going to introduce and implement PECS. And if for some reason that doesn't work, we're going to assess it and see how it goes. And we can keep other IBTs such as applied behavioral analysis or cognitive behavioral therapy as considerations if for some reason PECS isn't working for him.
And one other thing I forgot to mention was that the parents are really pushing for PECS. They weren't really interested in IBT, which is why we came up with the decision that we did, because it's the patient's values and opinions that really matter the most. So they were really pushing for PECS.
So in terms of future research, we think that there needs to be more direct comparison between PECS and IBT, and then more research is needed on how IBT improves specifically social skills, and also there needs to be more studies looking at the impact of social skills, specifically apart from communication skills.
So yeah, now okay, looking back on this project, and maybe if we were to kind of change up our PICO question a little bit, or maybe make a different comparison, maybe that's something the first year students could do. You know? How about comparing video modeling versus text? That could be interesting. So video modeling might be where Tommy would observe someone acting out a behavior, or maybe that would be an adult, maybe that would be an age, appear in the same age, like, for example, watching a child brush his teeth. This could potentially benefit some of his limited social behaviors, so maybe that could be an interesting comparison when looking at that as compared to PECS. Anything else to add?
And then the one reason we chose these two is because where PECS and IBT are relatively in the same area, PECS is more hands-on and they actually have something that they're doing, where video modeling is more hands-off and they're just watching. So those two really would be interesting to compare because they're two separate fields. All of our references.
And then we also just want to thank Dr. McCarthy and Mrs. Taylor for your expertise.
So, any questions?
Well, I didn't want to break your heart, so I'm going to say yes to your question. So I guess one point you mentioned about the cons of IBT is it requires a lot of training and therefore a lot of time. But I think it could be interpreted as some sort of advantage as well if you can just train a lot of people in this client's environment context to all be therapists instead of just doing the therapy in the clinic. So it looks to me to be an ecologically more valid method of treatment.
Well, like you were saying that PECS is kind of like part of IBT. What are the programs that you can put under IBT besides PECS and EED?
So IBT is kind of the theory. It's intensive, one-on-ones most of the time, and really like you're honing down on it over and over and over again, which is what you do with PECS. Applied behavioral analysis is another form. There's early intensive behavioral therapy, and then there's also cognitive behavioral therapy. I think there's several others, but those are the ones that we directly hit in our research. We kind of had to search a couple of those terms as well to kind of get research to back up our question. So yeah, hopefully that helps.
It was a learning process. We learned a lot.
I have a question. Does the literature have an agreed upon set of operational definitions for social skills?
A lot of them looked at around the same one, but a lot of them didn't specifically say which social skills they were looking at. They just said social skills in general. I know a lot of the times there was joint reference, eye contact, I think turn taking, requesting, and initiating. Those are the main ones, but there wasn't any set, this is what we're looking at for social skills and this is what other people look at for social skills. A bunch of our articles just said there was an improvement of social skills. They didn't specifically say which social skills, so that's kind of where we would like future research on those specific social skills.
I think that's very much a problem because social skills are situation dependent.
Mm-hmm.
I've been very sociable the past hour because I've been sitting very quiet. Right? And other times you're sociable because you initiate,
right,
etc.
Right.
So that would seem to be a conceptual issue for the literature.
Right.
Thank you, everyone. If you would fill out those and just keep them on the
So-
table.